Hi everyone, my name is Moises Dominguez, and today we'll be talking about myasthenia gravis, an autoimmune disorder that affects the neuromuscular junction. But before we discuss this topic, it's important to have a simplified understanding of what the neuromuscular junction is. This is a chemical synapse between a motor neuron and a muscle fiber that allows the nervous system to communicate with the muscle, resulting in muscle movement. Here we have a motor neuron, or presynaptic neuron, termed this way because it's before the synapse. Within the presynaptic neuron, you will find synaptic vesicles that contain acetylcholine, the neurotransmitter or the chemical messenger of the neuromuscular junction. The action potential traveling down the axon eventually causes the neurotransmitter to exocytose, acting on acetylcholine receptors found postsynaptically, and through a number of steps leading to muscle contraction. So how does this disorder occur? In most cases, it is typically due to auto or self-antibodies that are directed against nicotinic acetylcholine receptors on the skeletal muscle surface. This in turn decreases the amount of the receptor in the postsynaptic membrane. In other cases, it is due to autoantibodies against muscle-specific tyrosine kinase, also known as MuSK, which is a protein within the skeletal muscle. The big picture that we should have in mind is that autoantibodies directed against these proteins will make the muscle less responsive to acetylcholine, and this is categorized as a type 2 hypersensitivity reaction. So based on the pathogenesis of this disorder, we can conclude that patients present with skeletal muscle weakness, with the cardinal feature being fluctuating and often fatigable. Patients may feel weaker with repetitive movements, such as going to the gym, and their symptoms may feel worse at the end of the day. Although this disorder can affect any group of skeletal muscle, most patients present with ocular manifestations, such as diplopia or double vision, and ptosis, or eyelid drooping. Note that this disorder can affect patients of any age. However, there seems to be a bimodal distribution, with the first peak being around the second to third decade. In this patient population, it's female predominant, and with the second peak being at the 6th to 8th decade, which is male predominant. There are tests that we can perform that can further support our clinical suspicion of a patient having myasthenia gravis. Bedside tests include the ice pack test and the edrophonium test, also known as the tensilon test. To explain this further, let's go back to our neuromuscular junction illustration. Within the synaptic cleft, there is acetylcholine esterase, an enzyme that breaks down acetylcholine. With regards to the ice pack test, if we were to place a glove filled with ice or a bag filled with ice over a patient's ptosis, the decreased temperature will change the kinetics of this enzyme, and thus decreasing its activity. This will in turn increase the amount of acetylcholine within the synaptic cleft. Similarly, edrophonium increases acetylcholine within the synaptic cleft, but it accomplishes this by inhibiting acetylcholine esterase. Therefore, in both of these tests, the increase of acetylcholine within the synaptic cleft will improve muscle strength in the affected muscle. Serologic testing is used to detect the presence of these autoantibodies against acetylcholine receptors, as well as muscle-specific tyrosine kinase. We can also use electrophysiologic testing, such as repetitive nerve stimulation and single-fiber electromyography. To illustrate, let's focus on repetitive nerve stimulation, showing two graphs, one in a patient without myasthenia gravis and one in a patient with myasthenia gravis. In the y-axis, you can see the potential, which is measured in millivolts, and the time, which is measured in milliseconds. Every time we were to stimulate the nerve, there will be an action potential, and this is called the compound muscle action potential. In myasthenia gravis, with repetitive nerve stimulation, you can see that there's a decremental decrease in the action potential amplitude. As opposed to patients without the disorder, you do not see this decremental decrease. This goes in keeping with the clinical presentation of patients with myasthenia gravis. When these patients repetitively use their muscle, it subsequently leads to muscle weakness. And lastly, there's imaging. Imaging of the test, which can be accomplished with computerized tomography, is important to detect the presence of a thymoma, as myasthenia gravis can be a paraneoplastic syndrome secondary to this. And now for treatment. There are a variety of treatments that we can use in patients with myasthenia gravis. For symptomatic improvement, acetylcholine esterase inhibitors, such as pyridostigmine, can be used, sharing the same mechanism of action as edrophonium. Immunosuppressants, such as prednisone, can be used as chronic immunomodulatory therapy, which makes sense because this is an autoimmune disorder. Plasmapheresis and intravenous immunoglobulins are considered rapid immunotherapies that are used in certain clinical situations such as myasthenic crisis. This is a life-threatening condition that can be due to respiratory muscle weakness, requiring the patient to be intubated. And lastly, there's surgical removal of the thymus, also known as thymectomy, in patients who have a thymoma, and this can provide long-term benefit. This implies that the thymus may play a role in the pathogenesis of myasthenia gravis. I sincerely hope you found this video helpful. Please provide any comments, feedback, or video requests, and be sure to subscribe and like the video. Thanks.